Hi, so today I'm going to talk about bones and hormones. Really important actually, and a lot of people don't associate the two together because, as many of you know, when we talk about menopause or perimenopause, it's always been defined as period stopping or periods changing, or sometimes about fertility. And as many of you hopefully know, I really believe, and so do many others, that it's more important to be thinking about the menopause as a hormone deficiency that affects every single cell in our body. Now, our bones are really important. We all know about our skeleton, which helps keep us upright. Our bones are really important for the way our muscles attach and move. But our bones aren't just solid structures that are just static. They're really dynamic. So our bones actually produce lots of chemicals. They produce what's called cytokines, so chemicals that help the bones build. But there's also cells that help the bone break down. So the building cells, if you like, are called osteoblasts, and osteoclasts break down bone. So they're in a constant. They work together there's a good balance between these osteoblasts and osteoclasts. You can imagine when you need to build bone, for example, if you've had a fracture or you're growing, when children grow, there's more osteoblasts to build the bone. And then if you get the wrong balance and get more osteoclasts, you get breakdown of bone, the bone turns over. But there are lots of other chemicals that determine the way our bones function. And then in the middle of our bones is our bone marrow, really important for creating our blood cells actually. So our bones are not just thought of as sort of coat hangers for our cells and our cartilage and our skin to hang off. They are really important, biologically active substances, if you like, in the body. They're also really important for our calcium metabolism as well. So we know that there are certain nutrients that help keep our bones strong. So for example, we all know that having calcium in our diet, and calcium rich foods often obviously include milk, cheese, yogurt, cream, but also quite a lot of vegetables and pulses contain calcium too. So they're really good for building our bones. The other thing that's very important is vitamin D. So certainly we should all be taking vitamin D, whether we're male or female, whether we're adults, whether we're children. Everybody should take vitamin D, especially in the winter months, because vitamin D is actually a hormone as well. And the most we can get from is from the sunlight. Now, many of us, especially over the winter months, are not exposed to enough sunlight to have adequate vitamin D. And vitamin D is very important for calcium metabolism in our bones. It's also actually really good. It's a very anti-inflammatory hormone. It works and helps our immune system as well. And it's related or associated with quite a few diseases if we have low vitamin D levels. But today I'm just talking about bones, not vitamin D. But vitamin D is essential for good bone health. So any of you that aren't taking vitamin D, you should, whether you've got a risk of bone thinning or not. And usually the doses vary, but usually the recommended dose is either 400 or 1,000 international units, which is 10 micrograms or 25 micrograms. Usually I recommend 1,000 international units every day, or 25 micrograms to people, because if their level's slightly low, that will top it up. And it's still not a mega dose. So most people, it's the dose that I take and my children take. Usually I tend to take it throughout the year, mainly because I spend a lot of my time inside working. But if you're in a sunny environment, then usually don't have to take it during the sunshine unless you've been recommended to, of course. So our bones are very important, and also we have cells that respond to our hormones, oestradiol, progesterone and testosterone, those three magic hormones that decline when we're perimenopausal and menopausal. So why do we have cells that respond in the bones? Well, of course, we know that those three hormones help build the bone. They help make the bone strong. And strong bones are really important because obviously we don't want to be fracturing. So we know, and the studies have been there for many, many years, decades in fact, that when women are menopausal, when the hormone levels are low, they have an increased risk of osteoporosis. Now, osteoporosis is thinning of the bones. There can be some confusion. When I was Googling osteoporosis earlier, it comes up with brittle bone disease. You have to be really careful here, because brittle bone disease is actually osteogenesis imperfecta, very different genetic condition, not the same as osteoporosis. So I will just mention osteoporosis. I'm not going to be talking about brittle bones. Osteoporosis is when bones thin. Now, it's actually a diagnosis that we have to make from an investigation. I can't look at a patient or examine a patient and say you've got osteoporosis. So the gold standard investigation for diagnosing osteoporosis is a DEXA scan, which is a very, very low dose X-ray, where people, it's not painful, it's very easy. You just literally lie down and there's a little thing, it depends on the machine, but there's usually a little thing over. You're not in a tunnel, it's not claustrophobic at all. Takes between 10 and 20 minutes, and it will literally assess the density, so the thickness of your bones in your neck of femur, so which is in your hip joint, and also in your back as well. So you normally get two values, three, one for your spine, and then one for each hip, your left and your right hip, and it's called neck of femur, which has been confusing. One patient a while ago said to me, "Why are you doing my neck?" And I said, "It's not, it's the neck of the femur." So your femur is your thigh bone, and into your thigh it's like a ball and socket joint, and so the ball of the hip is connected into the femur by this, it's called the neck, so it's just like a little stump really, and so it's looking at that that area to see what the thickness of the bone is. Now, in osteoporosis, the bones become thinner, so if they become thinner, they're more likely to fracture. And this is where the problem is with osteoporosis. Osteoporosis usually doesn't cause any symptoms. So people sometimes come to me and say, "Oh, I'm getting some pain in my muscles and joints and I'm worried I've got osteoporosis because my bones are sore." Sore bones doesn't usually equal osteoporosis. There are reasons why people can have sore bones, and actually it's a very common symptom of the perimenopause and menopause when hormone levels are low. But actually osteoporosis often doesn't cause symptoms. But when people have a DEXA scan, there's some of you might have seen, you get a result and you get a score, and it's usually a negative score actually. And what they do is they compare the score to someone of your age as well, and sex, because male and female and different ages are sort of allowed to have different levels, if you like. And you usually get a graph, so there's a red, a yellow and a green part of the graph. No surprise, if you're in red, it usually indicates you've got osteoporosis. The yellow means there is some thinning, and it's usually defined as osteopenia, which means some thinning of the bone. And the green is you're good to go, your bones are strong. But obviously doesn't mean because you're green at that time, they're going to stay green, because it all depends of how your bone health is going forwards. Now, we know that when people have osteoporosis, they have an increased risk of a fragility fracture, and a fragility fracture is a low impact fracture. So for example, if I was cycling at speed, fell off my bike, banged my hip and broke my hip or my leg, it's not going to be a low impact fracture. So anybody, even if their bones were strong, could still have a fracture. Whereas if I just tripped over my foot and then just sort of fell very low speed onto the floor and broke my wrist or my hip, then it's more likely a fragility fracture. So it's not a fall that you would expect necessarily to have a fracture. And those fractures are more common, far more common in fact, in people who have osteoporosis. Now, having a menopause increases incidence of osteoporosis, but there are other risk factors as well. So some people have a family history of osteoporosis. So if your mother, auntie, grandmother, sister have had osteoporosis, you're more likely to have osteoporosis. People who smoke, who drink regularly or drink alcohol regularly have an increased risk of osteoporosis. Also, actually, people who are underweight can have an increased risk of osteoporosis, and also people that have had eating disorders as well. So people who've had anorexia in the past. Sometimes people don't always know that they've got osteoporosis, but if you've seen on my Instagram this week, we've actually posted an article about eating disorders and menopause, and so we know that menopause can unmask some eating disorders if people have had it before, which is a double whammy for the bones. But I've seen and spoken to a lot of women who've had an eating disorder in the past. Their periods have stopped, they haven't really thought about their hormones, and then they've had a stress fracture or a fragility fracture and found to have osteoporosis at a young age. So it's worth thinking about risk factors for osteoporosis. But I've already said the longer a woman is without her periods, as in the longer she is menopausal, the greater the risk of osteoporosis. So women who have an early menopause or POI, so premature ovarian insufficiency, and I've done an Instagram live about that already, if they're under the age of 40, they really do have an increased risk of osteoporosis if they don't have treatment with hormones. And so actually the guidelines recommend that women should have a baseline DEXA scan when they've been diagnosed with POI, premature ovarian insufficiency. I actually feel that everybody should have a baseline scan, male and women, when they're in their 40s or 50s, or earlier if they've had an earlier menopause or they've got risk factors, or because you want to know. You don't want to wait till you have had a fracture, and many people aren't being diagnosed until they've had a fragility fracture. Now, we know that the incidence, if you go onto the Royal Osteoporosis Society website, the incidence of osteoporosis in women over the age of 50 is at 1 in 2. So 50% of women over the age of 50 are likely to have osteoporosis at some stage in their life. Men, it's less common, it's about 20%, so 1 in 5 men. And what is the difference between men and women in their 40s and 50s and 60s? Of course, hormones really do have a play. I don't think it's just a gender thing or a genetic thing. It is very much likely to be related to our hormones because, as I've already said, oestradiol, testosterone, progesterone respond to the bones. So actually, when we have estrogen in our body, our bones become stronger. So this osteoblastic activity, the osteoblasts, the building cells in our bone, if you like, work better. The way that the vitamin D is used, the way that calcium is used in our bone is a lot more efficient when we have estrogen in our bones. And in fact, fun fact here for you, that our bones make estrogen as well. So it's not just all coming from our ovaries. I've said before that our brain produces estrogen, progesterone, testosterone, but our bones do as well, certainly estrogen. And so we know that when our levels reduce, so as many of you know, during the perimenopause, that time when symptoms start to creep in, even if people are having periods that often change in nature or frequency, once our hormone levels decline, there's a rapid increase bone turnover, increased bone loss, increased incidence of osteoporosis. So the incidence will go up gradually and then really go up quite fast during the perimenopause and menopause. And we lose a lot of our bone density very quickly in that period of time. And it carries on actually reducing. And so some people might notice that their skeleton changes. So a lot of people actually, if you've listened to my podcast with Dr. Saj Rajpal, who's a dermatologist, he talks about how he can see people's jaw changes actually, and often people find that they have sort of looser, saggier skin, and it's not always just related to the skin changing. He talks about the table and the tablecloth, and if you think the table is our jaw and the tablecloth is our skin, if the jaw is shrinking, so your table's getting smaller, then the skin will just sort of move over. And so he says a lot of people find that they have sagging in their skin and their jaw is withdrawing. Also it can affect the way the mouth is as well. But if that's happening externally in our jaw, of course it's happening internally in other bones as well. Some people find that their posture is affected. when the bones are becoming thinner. But the big problem, like I've said before, is the fragility fractures. Now, I've explained about this ball and socket joint in our femur, in our thigh bone, and if you see a picture of it, you've got this ball, little stump, and then you've got the thigh, I can't speak tonight, the femur, the thigh bone. Now, that little stump is the bit that fractures usually, or you can have a fracture of the whole femur as well, depending on the type of fracture and the fall, all sorts of things. But actually, having an osteoporotic hip fracture, now they occur, studies have shown, in around 1 in 3 women over the age of 50. Very, very common. It costs the NHS, guess how much a year, for these osteoporotic hip fractures to be repaired. It's at least 2 billion, not million, 2 billion pounds a year to manage osteoporotic hip fractures. And when I heard that a few years ago, and that was a few years ago, so it's probably even more now, I thought the person told me was misquoting. I really thought it was million, not billion. And I went and searched, and indeed it costs a fortune. But it's more than that. It's costing lives as well. So we know from studies that if someone has an osteoporotic hip fracture, which means a fragility, low impact fracture that's been as a consequence of osteoporosis, then the mortality, so the death rate after a hip fracture due to osteoporosis, is around 20% in 1 year. So that means if 5 women have a fracture due to osteoporosis in their hip, then 1 of them will die within a year. That's really stark, actually. Now, sometimes it might be the death might be related to the reason that they've fallen. So, for example, someone might have had a stroke and fallen, and it was the stroke that actually caused their death rather than the hip fracture. It's very hard to tease out from the data. But actually, a lot of people, if they've had a hip fracture and go to hospital and they're a bit frail anyway, they're more likely to get an infection, they're more likely to have sepsis, they're more likely to maybe have pneumonia or a urinary tract infection. And we know that 20% will die after a year. Now, if someone had been diagnosed with most types of cancer, the mortality is not 20% in a year. Even if they'd had a heart attack, mortality is not 20% in a year. So it's really important. And actually, osteoporosis doesn't get enough headline, actually. It doesn't get enough attention because it's just thought of, oh, it's just a bone disorder. Oh, it doesn't cause any symptoms. So if you look at the funding for research for osteoporosis, it's not nearly as high as it should be, when it's something, I've already said, that affects 1 in 2 women over the age of 50 and 1 in 5 men over the age of 50. So very, very common. And so when people have a fracture, obviously there's a death rate, I've already said, but it often can really reduce mobility and independence. So when I was a GP, I'd see a lot of women who'd had a hip fracture in the past, and they were just about managing at home. They often had some carers coming in, but they were tottering around at home in their own space, which was very safe. And then suddenly they'd have a fracture and they wouldn't be able to be independent again. They wouldn't be able to go back home, so they'd often have to go to a nursing home or a residential home. Would often really confuse them. Wouldn't be nearly as settled, have all sorts of other problems as well, and stemming from having the hip fracture. And also it's painful having a hip fracture. They usually have to be operated on. It's a long stay in hospital. So there are lots of reasons why we want to try and prevent hip fractures. But it's not just hip fractures that occur in osteoporosis, actually. Wrist fractures can be very, very common, especially a fall onto the outstretched hand can increase the incidence of wrist fractures, especially in osteoporosis, because we should be able to cushion our fall. But if our bones are weak, you can imagine it's very easy to break them. But also, osteoporosis or osteoporotic fractures of the spine are very common. Now, we've all seen stooped people, this sort of question mark posture, which was more common, not as common, but you still see it quite a lot when people are out walking in the street. So men and women, this stoop posture. And what often happens is you get these little fractures in the spine, and also with osteoporosis, often the cartilage in between each spine spine becomes thinner and not so cushioned. And so when you've got lots of little fractures, you get some curvature of the spine. And lots of little fractures in the spine are really painful actually, but also if you can imagine, if you're stooped like this, it can often be quite hard to digest food because you're bending over on your stomach. And also if you've got if asthma or COPD, or you're more prone to chest infections, you can't breathe. Obviously if you've got nice big expansion of your chest, you're more likely to be able to breathe in and out. Your lungs expand very freely, and when you exhale, your lungs collapse, and you can really make a difference. But you all know if you go like this, it's not so easy to inflate your chest. And so often people, when they've got osteoporosis of their spine, they are more prone to having chest infections, more prone to having breathing problems, as well as digestive problems, as well as being in pain. And I used to doctor a lot of people with osteoporosis of their spine and give them often quite strong painkillers. And then a lot of painkillers have side effects. They can also lead to constipation and nausea, and then medication is given for that as well. So you can see quickly how you're given lots of medication for osteoporotic fractures, especially when you can't usually do an operation to help to repair these little fractures. The other thing, any bone can fracture, and I heard a really awful story a couple of years ago. It's one of my patients told me that her mother, who wasn't very old, she was in her late 60s, and she was just carrying some washing down the stairs and she tripped. And she actually fell and broke her neck and then became paralysed. Her arms and legs became paralysed. And she was found to have osteoporosis. So a trip that she might have actually not had such a catastrophic injury, her bones were very weak. And so the weakness led to the fracture. So I'm sorry, this is all very depressing, but it's important to know that osteoporosis is real and it's out there, and we need to be diagnosing it more. And one of the things I did when I first opened my clinic, as many of you know, I didn't have any financial investment for my clinic. I got a bank loan, and I got a bank loan big enough so that I could buy a DEXA scan. And everyone thought I was mad, but actually it's so important. And I've done a lot of scans, or requested a lot of scans, for women who don't have risk factors other than being menopausal. They're otherwise fit and well, they've never had a fracture. They go in the machine and they found to either have osteoporosis or osteopenia. It's really important that we know, because then we can do something about it. And that's what I was saying. I feel that everybody, men and women, should have in their 40s and 50s a DEXA scan just to see where they are, because there are lots of people who are fit, active, eat really healthily, and it might be because of a family history, it might be for a reason that we don't know, have an increased risk of osteoporosis. So if you know what's going on in your bones, you know what to do about it. Having a normal x-ray or a CT scan or an MRI scan is not going to tell you your bone density. There are lots of companies that do a wrist scan or a foot or heel scan, and again, they're not sensitive enough. They're not the gold standard. So the gold standard is to have a DEXA scan. There's often quite a long waiting list at NHS, and even privately, you have to be really careful who's reporting on the scans. And if you've had a DEXA scan before, you should have the repeat one on the same scan. I was Googling earlier, looking at some of the private clinics that have DEXA scans, and some of them are very cheap, and then you see that they're not actually reported on by someone who's trained. And so that's really important to know what the scan is and who's reporting on it as well, because you want to make sure that you have someone who's really very good and has had the right training to report on the DEXA scan. Now, a bit of good news before I finish is that there is treatment, both actually for osteoporosis, but also to reduce osteoporosis. We know, I've already said, that vitamin D is really important. Also, exercise is really important. Every time you do exercise, especially weight-bearing exercise, if you're putting weight through your bones, it's going to help stimulate them to set off these reactions, and also it make the cells work better to build the bone. So if we're sedentary all day, keeping very still, our bones are not going to have the same impetus to repair and to get stronger. So weight-bearing exercise is really, really important. So make sure you think about the type of exercise that you're doing, and you might have to modify it as you get older, or if you've had a scan that shows that you have some osteoporosis or osteopenia. Now, the other thing to add, actually, before I talk a bit more about treatment, is investigations, because someone asked me, and thanks again for all your questions, there were a lot, asked me about having a calcium blood test. Now, a calcium blood test isn't going to show us the calcium level in our bone. So you need to make sure you have enough calcium in your diet. And there are calcium calculators. If you Google calcium calculator, you can see what you need and what sort of food as well that you can get calcium, different levels it will say usually in the information. But doing a calcium blood test is not usually accurate to determine what level of calcium is in your bones, and there isn't a blood test for osteoporosis either. Now, nutrition, really important. Not smoking if you smoke, reduce alcohol if that's possible. Also looking at weight-bearing exercise. Whether we have osteoporosis, osteopenia, or healthy bones, we should be doing that anyway for our future health, of course, because the risk factors for osteoporosis are the same as risk factors for other inflammatory diseases, because osteoporosis is an inflammatory disease. So that means if you increase risk of osteoporosis, usually there's an increased risk of heart disease, type 2 diabetes, clinical depression, dementia, even some of the autoimmune diseases as well. They're all related to inflammation. So anything we can do to reduce inflammation will usually reduce risk of osteoporosis as well. Now, at the beginning, I'm sure you remember, I said that our bones have cells that respond to oestradiol, progesterone, testosterone. So guess what? If you give those hormones back, you're going to reduce the incidence of osteoporosis, which is really important that we know that. So many people are talking about using HRT just to help flushes and sweats. And I've already said there are many, many symptoms that HRT will help with, because our hormones work all around our body. Now, we know, and we've known for many years, that women who take HRT have a lower incidence of osteoporosis compared to women who don't take HRT. Now, I'm not saying that people who don't take HRT are guaranteed to have osteoporosis. I've already said 1 in 2 women over the age of 50 who don't take HRT will get osteoporosis. So there will be many reasons that why we can protect our bones, but it is fact that women who take HRT, especially with estrogen in it, will reduce their incidence of osteoporosis. There's some good studies also that show that progesterone, the natural progesterone, not the synthetic chemically altered progesterone, but the natural progesterone. So in the UK, it's Utrogestan. We know that will help build bone and reduce osteoporosis. Testosterone as well in men and women, and obviously if men have osteoporosis without an obvious cause, then they should be thinking about their testosterone levels as well, but we know that having testosterone can help build bone as well. So HRT, including testosterone, can reduce the incidence of osteoporosis, but also it can be a treatment for osteoporosis. HRT is actually licensed, did you know, as a treatment for osteoporosis. Now, I've spoken to so many specialists who manage osteoporosis and they never prescribe HRT. It's a real shame, because they're really missing a trick. So we know that HRT will help reduce incidence of osteoporosis, also osteopenia, will help keep bones strong. So if you've had a normal DEXA scan, it's more likely that it will stay normal if you take HRT. Because I've already said, as soon as your hormones drop, your bone density drops quite quickly as well. And osteoporosis can be treated by HRT. Really important people know that. Now, there are other treatments for osteoporosis, and I'm not going to go through them in huge detail, but the most common treatment is a group of drugs called the bisphosphonates. and they help build the bone, and they're different to the way they build the bone with HRT. HRT is just the biologically active hormones that go back into the body to help build the bone. Bisphosphonates obviously aren't natural, but they do build the bone in a different way, and they make the bone very strong, but also quite easy to break as well. So if you think what you want to do is your bones to be slightly supple and flexible, so that if you fall, they're not going to shatter. Whereas when people have had bisphosphonates, often the bones become quite sort of strong and easy to break. So a bit like a sort of champagne glass or wine glass, very rigid, but if you break it, it's less likely to, or it's more likely to break. So it's a difference between dropping a glass and dropping a plastic tumbler. They both could break, but the plastic tumbler is less likely to break on a hard surface. And this is one of the problems, because when I speak to orthopaedic surgeons who are repairing fractures from people that are taking bisphosphonates, they say often it can be very hard, especially if someone needs to have screws in the bones to sort of repair the thigh bone. Then it's harder to actually repair because the bone structure is quite different. Bisphosphonates often have to be taken when people are sitting upright. There's a length of time before they can eat, and it can be quite a faff actually. I see a lot of people who have been prescribed bisphosphonates. And I used to go around to do visits at people's houses, and I'd look in the cupboard to see how many drugs they hadn't taken, and literally falling out would be always the packets of bisphosphonates, because people would say it's just too much of a hassle, I don't like it, I sometimes get some reflux, and it doesn't suit them. There are different types though, so now we've got ones that people can take once a week or even less frequently, and some people have infusions, so they have actually a drip or an injection of the bisphosphonates less frequently. So there are options, and they can be very, very effective. There are other drugs as well that's specific for treatment of osteoporosis, and there are new ones coming out. If someone's got severe osteoporosis, then there's no reason why they can't have HRT as well as the bisphosphonates or some of the other drugs. But it's certainly worth, if you're thinking about or you've been advised to take a bisphosphonates, it is worth asking, can I take HRT as well? Because HRT will work differently and it's very effective. And like I say, it is licensed as a treatment for osteoporosis too. So HRT and testosterone. You should be the body identical hormones because they're more biologically active. They will work better on the bones to make it stronger. There are some studies that show even older women, so women in their 70s and 80s, who have a low dose of HRT prescribed to them, low dose of oestradiol, you can still build their bone. So we shouldn't be excluding HRT as a treatment for osteoporosis if someone's had a fracture when they're older as well. And we're very fortunate now because, like I've said before, we've got the oestradiol that we can give at very low doses. So often we can give the oestradiol gel very low dose and gradually increase, knowing that we're helping improve the bone density and the natural progesterone and possibly testosterone as well. We also know, and I've said before, that these hormones actually help our muscles as well and help muscle strength and function. So for our bones to be working well, we want our muscles to work well as well. So it's an added benefit as well. So if we're stronger, we're less likely to fall, and if we do fall, we're more likely to be able to react and reduce the impact of that fall. Even then, when we fall, we're less likely to break our bones as well if our bones are strong. And so certainly one of the reasons, I've said it before, that I take HRT is because I'm scared of osteoporosis. I've seen a lot of people who have been in a huge amount of pain because of their osteoporosis, especially of their spine. And we've got such good evidence that HRT reduces incidence of osteoporosis and keeps bones strong. Of course, just taking HRT isn't going to be enough. I'm really careful about the exercise I do. I look at the calcium intake in my diet. As many of you know, I don't smoke, I don't drink any alcohol, so I eat really healthily as well. So looking really holistically what we can do for our bones is really important. I have a regular DEXA scan. You don't want to have them too regularly. If your bone density is good, then often people say just have them every 3 to 5 years. If you've been diagnosed with osteopenia or osteoporosis, go with the advice of your healthcare practitioner, but we don't say to do them too frequently because it can take a little while to see an effect and to see your bone density improve. So I hope that's been helpful. Next week it's Mother's Day, as many of you know. So I'm going to do an Instagram live about relationships and families and how menopause and perimenopause can affect not just us as menopausal women, but those around us who we love and adore, and also how we can start maybe the conversation. So if we think the menopause is affecting our mother, our sister, even our daughters, how we can bring it up, or our partners as well. So there's no reason why male partners or men there's no reason why they can't log on next week and have a listen too. So I hope that's been useful. A lot of information, but I hope now you think about bones in a different way. I will put on some information on my story that we've written and developed about osteoporosis. I'll load this onto my Instagram grid, and if you've got any questions or ideas for future Instagram lives, then let me know. So enjoy the rest of the evening and have a really good week. Thank you.